It's important to recognize that deep venous thrombosis affects approximately 2 million people per year in the United States, and that the signs and symptoms of a DVT are nonspecific. The reason we're so concerned about diagnosing a DVT is because we're trying to prevent the sequelae of a pulmonary embolism, which will occur in about 50 to 60% of untreated patients, and of those patients, there will be an approximate 25 to 30% mortality rate, which is obviously significant, and therefore it's important that we make this diagnosis early. When we perform this examination, we're trying to answer a simple focus question, and in this case, does this patient have a DVT? Now, the focused lower extremity compression exam that we're going to be discussing in this lecture is going to be a compression exam that goes from the groin, where you'll be looking at the common femoral vein, and you're going to be going down to the knee and looking at the popliteal vein and ending where it trifurcates. Color Doppler is not going to be required for this exam, nor is the maneuver of augmentation going to be required in the performance of this examination. So the important thing to remember with this examination is that isolated calf DVTs will not be excluded based on this proximal compression lower extremity exam. So this leads us into the debate of, should you scan the calf veins? And there's a lot of debate about this, and I'm not going to spend a lot of time on it, but basically the pros for scanning the calf vein include there's about a 20 to 30% propagation rate of calf DVTs. There's about a 5% risk of developing a pulmonary embolism from a calf DVT, and there's about a 4 to 10% risk of potential bleeding while being on Coumadin. So those things have to be weighed against each other when deciding to perform the exam and then deciding whether to treat an isolated calf DVT. Looking at scanning the calf veins in a negative, from a negative perspective, scanning of the calf vein is going to be less accurate due to technical difficulties. Isolated calf DVTs are rarely treated clinically, and you've got the option of doing serial scans from the common femoral through the popliteal veins in a window of 72 to 96 hours in the medium to high risk patient to look for evidence of propagation. So the bottom line here is you really want to follow your institutional guidelines. Another question that frequently comes up is, do you want to scan both legs? The bottom line here is you should scan both legs if the patient is symptomatic in both legs, but you do not need to scan both legs if the patient is only symptomatic in one leg. A lot of you may be thinking, since I earlier had stated that we're not going to be discussing the use of color Doppler, how can we do a lower extremity DVT exam without using color Doppler? And it's important to remember that the mainstay of the diagnosis centers around the sonographic appearance of the vessel lumen and whether or not the vessel is compressible. The Doppler findings are secondary, and you can perform a highly accurate proximal lower extremity DVT exam without the use of color Doppler. So let's now look at some of the exam essentials. From a transducer perspective, our main workhorse transducer is going to be the 5 to 10 megahertz linear transducer, and that'll be an adequate transducer for the thin to average size adult. However, in the larger adult, you may need to use a 2 to 5 megahertz curvilinear transducer. From a positioning standpoint, it's best to keep the patient in a little bit of reverse Trendelenburg with their leg comfortably externally rotated. When doing the compression portion of the ultrasound, it's always important to remember that the compression is going to be done in the transverse plane. This way you're able to fully see the vessel and see it collapsing or seeing it not collapse. When you do it in the sagittal plane, it'd be very easy to overcall compression if you're sidewalling the vessel. So compression should always be done in the transverse plane. So we're going to begin the exam high up in the groin in the transverse plane with the indicator directed towards the patient's right. So the first vessel that we're going to be coming across is going to be the common femoral vein. So here we are scanning proximally, transducers in a transverse position, indicator towards the patient's right. You can see the first thing you're going to notice is you're going to have the common femoral artery and the common femoral vein. Looking back at your anatomy, remember it's nerve, artery, vein when going from lateral to medial. Here you can see on this image right here, here's the common femoral artery, here's the common femoral vein. Now as we continue scanning down, you can see that this vessel is completely compressible. What you can see is as we're sliding down the leg, that the vessel that divides first is going to be the common femoral artery here into the superficial and profunda branches. But what you also notice here is you can see where the greater saphenous vein inserts into the common femoral vein. And this is an important window to visualize, since a patient who has a large clot burden within the greater saphenous vein that is close to the insertion point to the common femoral vein should be treated as a DVT. So you want to be able to visualize this point right here. And so here's just another look at that common femoral vein saphenous insertion, because like I said, it is an important area to scan. So here you can see superficial femoral artery here. Here you've got the deep or the profunda artery. You can see the common femoral vein here, and here you can see the greater saphenous vein coming in, and you can also intermittently see a valve right at that point right there. So remember, when you're scanning the common femoral vein, make sure you see the insertion point of the saphenous vein. Continuing to move in a caudal direction, we're going to go from the common femoral to the femoral vein. And what we're going to end up seeing here is that you've got the superficial femoral artery in the near field, followed by the superficial femoral vein. Then you're going to have the profunda vessels. And as we continue to move farther down the leg, you're going to end up seeing the profunda vessels go deeper and deeper, and we're going to end up losing them, and they are not the target vessels that we'll be scanning. We're going to be sticking with the superficial femoral vein, or more commonly called now the femoral vein, to eliminate any confusion as to whether or not it's part of the superficial or deep system. Let's stop for a second here because I want to go over a big point. At this level, venous duplication is extremely common. It can occur in upwards of a third of patients. So it's important that when you get to this level where the common femoral vein ends and the superficial femoral vein or femoral vein begins, that you look and verify the presence or absence of venous duplication, because you don't want to miss a clot burden that's in only one system. And this is a big risk if you're not aware of this fact that venous duplication can occur at this level. Here's an example here of a patient with venous duplication. You can see here's the superficial femoral artery, and here are the veins. You can see that there are two of them right here. And normally the veins in the thigh are going to be wider than the associated artery unless duplication is present. But just remember, at this level you've got to stop and make a conscious effort to look around to see if duplication occurs, because you just do not want to miss clot burden in an isolated system. Here's another patient with a duplicated system. You can see that as we continue to move down, here you've got the superficial femoral artery, the superficial femoral vein, and here you've got the profunda system, which is going to be diving deeper. Now what you can see is that as we're moving down, you can see that there are two systems here around the superficial femoral artery. So you've got to be aware of this and look to both of them and follow them to make sure that they are compressible and whether or not they have clot burden within them. Here we have a patient that does not have a duplicated system, but you can see here, again, we've slid the transducer down, continuing to compress as we go along, And here you can see the superficial femoral artery, superficial femoral vein, and then the deep system. And here you can see it on the video clip. There's the artery, there's the vein, and the profundus system is falling out of view here, but we're continuing to march along and intermittently compress with the transducer in the transverse plane and perpendicular to the skin. As we move down into the mid-region, again, we're going to continue to follow the superficial system. The profundus system will have fallen out of view by this time, and you just want to continue along in the transverse plane, intermittently compressing. If you lose the vessels at any time, your best bet is to move back up to where you last visualized them and then keep coming down. And you can see here we've got the superficial femoral artery. Here's the vein behind it, and you can see that it's easily and fully compressible. Now, as you move closer to the adductor canal, you're going to note that because of the musculature, it's going to be more difficult to compress the vein, and this is an area where you could potentially falsely diagnose a DVT due to inability to compress. And you can see here that we're down more distal by the adductor canal, and you can see here that you're going to first see in the near field the superficial femoral artery, and deep to that you're going to see the superficial femoral vein. You can see here you've got the artery and the vein, and you can see that initially on the first pass it wasn't compressible, but then you can see by using your other hand to squeeze from behind, you can see now that we're fully compressing the vessel, demonstrating the absence of a DVT at this level. Here you'll note that this is a patient without a DVT, but you can see that with transducer compression, you can't compress the vein. Therefore, it's important when you're by the adductor canal that you go ahead and use that two-hand technique and squeeze from behind in order to compress the vein. This may require you to use a second person in order to hit the freeze button, or if you're quick, you can, after compressing, hit the freeze button and then scroll back using the cine feature in order to obtain the desired image. Once we scan the distal superficial femoral vein, we're going to move to the back of the leg and begin scanning the popliteal vessel. And here you can see that with the transducer on the back of the leg and the indicator towards the patient's right, you're going to end up seeing the popliteal vein in the near field, which anatomically is going to be more posterior, and then you're going to end up seeing the popliteal artery, and you're going to follow that until it divides, and that's where the exam will end. The popliteal vein exam is going to be performed with the patient supine, with the leg flexed at the knee and externally rotated so that you can get the transducer into the popliteal fold, or in the decubitus position with the study side or study leg side up. You could also do it with the patient sitting and having their leg dangling over the side so that you can get behind there. Now here we are scanning the popliteal vein again. You've got the transducer in the popliteal fold, indicator towards the patient's right in a transverse plane. So here you can see popliteal vein in the near field, popliteal artery, and that's what you're seeing here on this image here is popliteal vein and then popliteal artery. And you can see that we're following it more distally. And again, you're just going to do compression ultrasound at these levels, and this is where the exam is going to stop. Just want to state one more time about venous duplication. Venous duplication is common at this level also, and it may have initiated up at the level of the femoral vein, but it also may start down in the popliteal vein area, so just be aware of that as you're scanning down so you don't miss clot burden in an isolated system. Here's a patient we were scanning in the popliteal fossa, and you can see here's the artery and here's a duplicated system here. You've got absence of clot in this system here, but in the more superficial or posterior system, you can see here that there's echogenic thrombus and lack of compressibility. So again, just be aware of the potential for venous duplication. When you were up by the common femoral vein, I told you to keep an eye out for the greater saphenous vein and where it inserts. The same applies here in the popliteal fossa. You want to look for where the lesser saphenous vein is going to insert. Here we've got a sagittal view here, so this is posterior, anterior, head and foot. So you can see that if we were in transverse plane coming down the popliteal vessel, that we're going to get to this point caudally here where the lesser saphenous vein inserts. And it's important to note this junction here because you want to be looking for the presence of clot burden within this vessel, since when it's very close to the area of the popliteal vein, one would have to potentially consider treating this as a DVT. Okay, so let's take a look at some pathology now. What is an acute DVT going to look like? First, because of the clot burden, you're going to end up seeing that the vein itself is going to be enlarged in relationship to the adjacent artery. You're going to see that the thrombus is going to be anywhere from anechoic to hyperechoic depending on how long it's been there. And an acute DVT, the vessel would be non-compressible. And here we can see that with transducer compression, this thrombus-filled lumen does not compress. All of this supports the diagnosis of an acute DVT. So the next question you have to ask yourself is, how much compression do I need before I call it quits? And really, in a normal vein, you should not have to be very heavy-handed or apply much pressure. But here you can see that we're tenting the artery and there's no compression of this vein, so clearly that's more than adequate compression. Here's an example here of two different patients, both of whom had acute DVTs. On the left here, you can see that the thrombus was more hypoechoic, and this ideally favors a more acute DVT, whereas here you've got a patient who has a more echogenic thrombus. So you want to keep your eyes out for both types. It can range anywhere from hypoechoic to hyperechoic. Earlier I mentioned you could use either a linear or a curvilinear transducer. Here you can see a patient that has a DVT in the common femoral vein here. At the junction here you can see of the greater saphenous vein. You can see that there's thrombus within the vessel here and it's non-compressible. But you can see that this also could be detected with a curvilinear transducer. So it's important to remember, if you have a obese or a very large patient, that you may need to go to this in order to get the needed penetration. Let's look at some examples of pathology. Here you've got a common femoral vein here, and you can see the vessel is much larger than the adjacent artery here. You can see that it's filled with medium level echoes, almost in a spongy appearance, and that it's not compressible. This all favors a diagnosis of an acute DVT. Here's another patient where you have a common femoral vein DVT. It's in the patient's left leg, so you've got from lateral to medial, you have nerve, artery, and vein. You can see the artery here. You can see the much larger common femoral vein filled with echogenic thrombus, and it is non-compressible. When you detect a thrombus in the transverse plane, you can scan up to the proximal border and turn on it sagittally to get a better look at the free edge. Here you can see a patient with a relatively large common femoral vein DVT, and you can see the thrombus here, you can see the proximal border, and you can see that this whole segment here is unattached to the wall and would be at high risk for embolism into the lungs. Here we have a patient with a clot in the femoral vein in the mid to distal region. Here you can see the more anterior artery, and here you can see the vein, which is enlarged compared to the adjacent artery here. You can see that it is very echogenic here, and it was non-compressible, consistent with an acute DVT. Here's a patient with an acute popliteal DVT. So your posterior, anterior, patient's right, patient's left. So here in the near field, or posterior, or more posterior from an anatomic standpoint, you've got the vessel here, and you can see that there's there are low-level echoes within the vein. The vein is enlarged compared to the adjacent artery, and you can see that it is non-compressible, supporting the diagnosis of an acute DVT. Even though we're performing a proximal lower extremity venous study, you want to take a look briefly after the point that the popliteal vein trifurcates to look to see if there is evidence of thrombus within the vessels right near that junction, since those should most likely be treated as a DVT also. Here we have a cancer patient who came in with findings suspicious for a DVT. If you look in this sagittal view in the area of the popliteal fossa, you can see that there's thrombus within this vessel here, which is in fairly close proximity to the insertion point of into the popliteal vein. On the transverse view here, you can see evidence of the thrombus here. There was no thrombus within the popliteal vein, but you could see that this branch of the posterior tibial system had thrombus in it. Because of the close proximity of the popliteal vein, this patient was treated and admitted to the hospital. Just a quick word here, I would be very cautious in attempting to differentiate acute from chronic DVTs unless you have an interval scan that's demonstrated resolution of the prior clot. Even the hands of experienced radiologists or vascular physicians, differentiating acute from chronic DVTs can be difficult. Here's a patient who was known to have prior DVTs in the leg but came in with acute leg swelling. If you take a look, things that favor an acute DVT here is, one, this patient has echogenic thrombus. They had lack of compressibility. The vein was enlarged as compared to the adjacent artery. And the big thing that you see here is that you've got a mobile proximal edge here. This is what's at great risk for embolizing. This all favors the presence of an acute DVT, so this patient was treated and admitted. We mentioned earlier about the superficial veins in the leg that you're going to want to look at, and they are the greater saphenous vein and the lesser saphenous vein. If you're away from the insertion point, you're going to note that these superficial veins are not accompanied by an artery, that there is a thin superficial fascial layer that's going to be surrounding these veins but not their tributaries, and that the presence of clot near or at the junction with the deep vein should be treated as a DVT. This is more clear-cut with the greater saphenous vein, but should also apply to the lesser saphenous vein. Here's a patient that comes in. Obviously, your first concern is, does this patient have a DVT? He's got a large swollen leg after a long travel history. You can see, though, that there's some erythema over the course of the greater saphenous vein here. And when we went ahead and scanned this patient, there was no evidence of clot within the common femoral vein, the femoral vein, or the popliteal vein. But as we followed the saphenous vein, basically from the insertion point all the way down, you can see that there is a large clot burden within here, and this patient was treated as an acute DVT after discussion with the admitting medicine service. Here's a patient who has a clot in the greater saphenous vein that again approaches the junction here. You can see there's clot burden right here, which is probably less than a centimeter away from entering into the common femoral vein here. and you can see that it extends all the way down the leg here, at least as far as you can see on this video clip. So again, this was a patient who was treated as an acute DVT. Here's a patient with a clot within the lesser saphenous vein that is very close to the junction of the popliteal vessel. Here you can see the clot in the transverse plane approaching the popliteal vessel. In the sagittal plane here you can see the clot burden. You can see the popliteal vessel, and you can see how close it is to that insertion point. So in conjunction or in discussion with the vascular service, this patient was also treated as an acute DVT. I also want to advocate here that when doing these studies, you have the advantage of evaluating the patient for the tender area, and I would advocate that after you do your focused compression ultrasound, that you scan over the tender area, because you may frequently find the diagnosis there. Here is a patient that came in with right posterior calf pain that for all the world looked like a DVT and denied any history of any significant trauma. But if you look, as we scanned over the tender area after excluding the presence of a proximal DVT, you could see that he's got a tear of his gastrocnemius muscle distally here, and that this was the source of his pain. Here's a transverse view here. You can follow this down distally, and you can see there's free fluid. Here was the tear right before the junction with the tendon. So this patient did not have a DVT, but had a tear of the medial head of the gastrocnemius muscle. Here was a patient that came in, had no evidence of a DVT, but looked like they had potentially a DVT. When we scanned them over the tender area on the posterior left calf, we were able to find that there was an isolated superficial thrombophlebitis, and scanning over the tender area was very helpful in making the diagnosis. It's not uncommon when scanning patients with lower extremity pain to come across Baker's cyst, and this may be causing the patient's clinical symptoms. These are synovial cysts. They communicate with the posterior bursa around the knee, and they may mimic clinically a DVT when ruptured. They can either be anechoic or complex in appearance, and you can see on this sagittal view right here, so your posterior, anterior, head, foot, you can see here's the communication with the posterior bursa, and you can see that this is the described beak appearance, and this is the fairly typical appearance of a Baker's cyst. Here you have a patient with a ruptured Baker's cyst. You can see that there is free fluid that's tracking in the subcutaneous tissue due to the rupture of the Baker's cyst. This was a patient that came in with an edematous lower extremity that clinically looked to be a DVT, but there was the Baker's cyst that had ruptured, and there's the fluid tracking in the subcutaneous tissue there. Here's one more example of a patient with a Baker's cyst. On the transverse plane, you can see here is the Baker's cyst, and as it moves more posteriorly, this is where it's going to communicate with the posterior bursa. And here you can see the sagittal view here, and the beak is over in this direction right here. Here you can see the vessels here. Earlier when we talked about making the diagnosis of a DVT, I said that it's important to make sure that a normal vessel is anechoic in appearance and that it is completely compressible. Sometimes you're going to see the presence of echoes, as you do here, within the vessel, and the vessel is still compressible. This would go along with spontaneous echo contrast or due to stasis. That's different than what you see in a second here, which is thrombus, which would make the vessel non-compressible here. So don't get confused with venous stasis and overcall that as clot. Still rely on whether or not the vessel is compressible. With venous stasis, The vessel may appear echogenic, but you see a swirling and not a fixed pattern, and the vessel will be compressible, unlike with a clot where you've got a fixed appearance of the thrombus and the vessel is not compressible. You don't want to confuse an enlarged inguinal lymph node as being a DVT. On transverse clips, they will appear as echogenic foci and they'll be non-compressible, but remember, they're of a fixed AP length and they're not associated with an adjacent artery. If you have any doubt over about what you're looking at, you can scan in a sagittal plane. Here's a patient with multiple enlarged lymph nodes. You can see the hyperechoic hilum here. So you do not want to rapidly put the transducer on and quickly make the diagnosis of a thrombus just based on the appearance. Make sure that it is indeed the vessel. Look for the presence of an associated artery. Here you can see the vessel's deep here and there's no thrombus in this patient. So let's take a minute and review some of the key points. First, the FOCUS study does not rule out isolated cath DVTs. Bilateral studies are only needed if the patient is symptomatic in both legs. Augmentation is not part of the focused proximal bedside EM study, and color Doppler interrogation is also not part of this study. It's possible that you could just do a 3-point exam instead of the comprehensive proximal exam that was shown in this lecture, where you just do one isolated point of the common femoral vein, one of the mid-femoral vein, and then of the popliteal vein. It is possible that a focused thrombus could be missed, although looking through the literature, focused or focal thrombus is very unlikely. I prefer doing the comprehensive proximal exam because I sometimes find in larger or difficult patients that finding the mid-femoral vein may take a little bit of time, and it's easier to just track the vessel the whole way down and just do quick compressions and then put in the chart the 3-point exam in terms of imaging. Lastly, let's look at some pitfalls of the exam. Remember, duplication is common in both the superficial femoral vein and the popliteal veins, and it's easy to miss DVTs isolated to one system. So be very cognizant of this and look for duplication at both those levels. If you do use color Doppler, remember, incorrect settings can cause the color to bleed over the clot and lead to a false negative exam. So never let color Doppler dissuade you from making a diagnosis based on your grayscale appearance. And lastly, remember, differentiating acute from a chronic DVT may be very difficult, and these patients may not be the ones you want to start your focused lower extremity exams out on. This concludes the focused lower extremity compression ultrasound video.